Well, welcome. Thanks everybody for being here. I'm Stephen Leckie. I'm going to be talking to you about spine emergencies today. I wanted to take a moment to thank all of our vendors who are outside who made today possible and also help us deliver seamless care in the operating room every day. These are my disclosures, none are directly relevant to this talk. As I was putting this talk together, I wanted to focus on spine emergencies that might be encountered by medical providers who are not emergency providers. So primary care physicians, physical therapists, chiropractors, et cetera, people who are seeing spine patients in the outpatient setting and may encounter a spine emergency that is not necessarily being received in the emergency room. So first we'll talk a little bit about the spinal cord injury, then what to do in the setting of a trauma. And this is not meant to be surgical management of spine trauma, but really every single one of you will at some point be a first responder to a trauma. It's inevitable. It'll be a car accident or a football game, or you'll witness a fall and you'll be the first one there. And as a nurse or a physical therapist or a chiropractor, you will probably be the most qualified person to protect that person's spine until emergency services show up. So there's a couple of simple first responder principles that are very critical. And then non-traumatic spinal emergencies, epidural abscess, hematoma, rapidly expanding tumors, rapidly progressive myelopathy, and massive disc herniation. We'll look at all of those briefly. This is the spinal cord in cross-section. This is the most important nerve in the body, and this is what we're trying to protect. All of this talk is about how do you protect the spinal cord, prevent damage to the spinal cord, or if there is damage, to minimize that damage. There are three important tracts in the spinal cord. Depicted in red, the corticospinal tracts, those are motor tracts. So signal from the brain goes down the spinal cord and then to the arms and legs, and it controls muscle. And of course, remember, this is bilateral. There's another one of these right over here. But the corticospinal tracts control motor. In the back of the spine, the dorsal columns are deep touch, vibration, and proprioception. Proprioception means your joint position sense in space, meaning you can close your eyes and you know where your arms and legs are in space. Spinothalamic tracts are light touch, and so those are ascending tracts. Sensory feedback comes in from the periphery, goes up the spinal cord and to the brain. When there is a very serious injury to the spinal cord, and that could be trauma, but it could also be an abscess or any of the other things we talked about, if that is a significant injury to the cord, then there may be spinal shock. Spinal shock is temporary paralysis, loss of reflexes, and there are hemodynamic changes that make it distinct from other forms of shock. So for example, hemorrhagic shock, there may be, if there's been a significant amount of blood loss, there may be hypotension, but there is a compensatory tachycardia. Spinal shock, on the other hand, is low blood pressure and bradycardia. It happens because the neurons become hyperpolarized and less responsive to stimuli, and usually it lasts 48 hours and then it ends. When spinal shock is over, then you can get a more accurate neurological exam and determine exactly what someone's neurological function is. And the way to determine that spinal shock is over is that the return of the bulbocavernosus reflex. That reflex arc is a sacral nerve root mediated arc where you pull on the Foley catheter and they will have contraction of the anal sphincter. And when that returns, you know that spinal shock is over, and you can determine at that point if their spinal cord injury is complete versus incomplete. In a complete spinal cord injury, there is no motor or sensory function below the level of the injury and no voluntary anal sphincter contraction. A complete spinal cord injury has a very poor prognosis. Regardless of what we do to stabilize the spine surgically or decompress it, most people will get a little bit of improvement. They may get 1 or 2 nerve root levels of improvement, but it is extremely uncommon to get all neurological function back when there is on presentation, a complete spinal cord injury. In contrast, incomplete spinal cord injuries have a much better prognosis. An incomplete spinal cord injury means that there is still some preserved function below the level of the injury. And incomplete spinal cord injuries come in 3 main types based on the anatomic region in the spinal cord that is injured. In a central cord lesion, this is extremely common, particularly elderly people who fall have a hyperextension mechanism, so low energy. The neurons in the center of the spinal cord are the most affected. Typically, this means that the arms are involved more than the legs, and the reason that's the case is within the corticospinal tract, the arm nerves are more closer to the midline than the leg nerve. So if there is an insult in the central portion, you'll get arm involvement, but the legs may be spared. This is the most common incomplete spinal cord injury, and the prognosis is overall good. Another form of incomplete spinal cord injury is an anterior cord injury, and this is often a vascular phenomenon. The artery of Adamkiewicz is one of the big important arteries that feeds the thoracic spine, and if there is an infarct, the ventral portion of the spinal cord may lose function. Posteriorly, there is a different blood supply, but anteriorly, you've got one major artery that feeds more than half of the spinal cord. It can be from direct compression as well, flexion-compression mechanism. Flexion and compression, of course, with falling forward, something ventral could then retropulse into the spinal canal. And as this often has a vascular infarct component, the prognosis for this is poor. The last of the incomplete spinal cord injuries is called Brown-Séquard, and that happens when half of the spinal cord is injured and half of it is okay. This is usually penetrating trauma from the side. And you have an interesting presentation where on the same side as the injury, you will damage the corticospinal tract and you will damage the posterior columns. However, you will get opposite side spinothalamic tract. And the reason that happens is the spinothalamic tract, when it enters the spine, within about 2 levels in the spine, it crosses to the other side before it ascends. Conversely, the corticospinal tract goes from the cortex, goes down the spine on the same side. It's crossed in the brainstem and then goes down the spine. And the posterior columns ascend on the same side and then cross in the brainstem. So if you have a lesion to one side, you will get the same side motor and proprioception, but you'll get the opposite side spinothalamic because that tract has crossed within the spinal cord. So it creates a very classic but unusual presentation neurologically. And the prognosis for this is typically good. The anatomy at the very tip of the spinal cord is unique. Remember, the spinal cord ends at about T12L1, and then below that there are nerve roots, no longer cord tissue, and physiologically that is very different. The nerve roots are much more tolerant of compression than the spinal cord can be. However, if you have a significant compression to the nerve roots, that is called cauda equina syndrome. And those nerve roots, that is called the cauda equina or horse's tail, because it obviously looks a bit like a horse's tail. And very significant compression there can result in lower extremity weakness, numbness, and potentially bowel or bladder continence problems because the bowel and bladder sphincters are controlled by sacral nerve roots. At the very tip of the spinal cord, that spot is called the conus. And if there is a lesion immediately in the conus, you can get isolated sacral nerve root injury that spares the legs. So in a conus lesion, there can be bowel or bladder incontinence, but the legs might be okay. And the reason is this is tapered at the tip of the spinal cord, and the nerves that exit first are the lumbar nerve roots. Here's the L1 pedicle and the L1 nerve coming off, L2, L3, etc. So they come off in order, and the last ones to leave the spinal cord are the sacral nerve roots. So this is a spinal cord injury. It's not lower motor neuron, but it is isolated sacral involvement. Now, all spinal cord injuries, not just cauda equina and conus, but the complete incomplete injuries, historically, it was standard of care to provide high-dose steroids to try to improve neurological function. And this came from some very high profile or high impact studies from the 90s that said high dose steroids will improve function. That is no longer believed to be true. So no longer are we giving high dose steroids, and the reason was not only does it not improve neurological function, but it has associated complications. People are getting pneumonia, they get wound dehiscences and so forth. So high dose steroids are a thing of the 90s. For all of these spinal cord injuries, the decompression should occur as soon as possible. The literature says if you can get to them within 48 hours, their outcome will be better, but that number is an artificial number. The way it's determined is retrospectively looking at what time point led to statistical significance in terms of improvement. So the reality is, as soon as feasible. Now, these people will often have other injuries that might slow them from getting to the operating room, or other comorbidities such as heart problems or stroke, or local resources that might slow them from getting to the operating room. But as soon as safely feasible is the right answer for all significant spinal cord injuries, whether they are traumatic or non-traumatic. So in the setting of trauma, this is just a couple of examples of significant cervical spine trauma. This is jumped facets, looking at the cervical spine from the side, vertebral body here and vertebral body here, and you can see a traumatic spondylolisthesis, meaning one vertebral body has slipped forward on the next, and the facet joints have perched, so this facet joint should be sitting over here, and as a result of this injury, it has jumped over like that, and typically with a significant spinal cord injury, that needs to be reduced and stabilized urgently. This is called a teardrop fracture, and although it looks relatively benign, it can actually be a very significant three-column injury because it will involve not only the anterior ligaments, but all the way across into the posterior ligamentous structure. So this X-ray finding is evidence of a possible three-column injury, also very potentially unstable. So what do you do as a first responder? You are at a football game, or you pull over because someone is in a car accident. All trauma protocols start with some very simple things that prioritize the most important and potentially life-threatening things that must be stabilized. So first is airway. Are they able to breathe? If they are able to speak, their airway is probably okay. You do not need to worry about things further down in the trauma protocol. If there's an airway problem, nothing else matters. So that's a hard stop. That problem has to be fixed before you move on. Significant chest trauma, such as pneumothorax, hemothorax, circulation and hemorrhage needs to be controlled. And then after that, deformity and neurological deficit. So major open fractures and a neurological assessment. And this is what we do in the emergency room, in the trauma bay. This is what you should be doing when you first come to someone and you're trying to prioritize in your mind how you should be thinking about this problem and triaging this person. The longest 10 minutes of your entire life will be waiting for an ambulance in the setting of a trauma, because you've stabilized what you can, but of course you're very limited in what you can actually do in the field. And waiting for emergency services to arrive can seem like it takes forever, even though it's just minutes. Rigid cervical collar in the setting of suspected spine trauma is a must for everyone. That also goes with supportive blocks on either side of the head to make sure that you're preventing any rotation, and a backboard to protect their thoracolumbar spine. You should assume that everybody who has been in a high energy trauma has a spine injury until proven otherwise, and so they need to be immobilized and protected. There's some special considerations for very small children. Remember, infants and toddlers have disproportionately large heads, and so if they are on a backboard that is a standard adult backboard, because their head is large, that will cause them to flex forward and can potentially misalign their spine. So pediatric backboards typically have a depression to accommodate their head, and you just have to be cognizant of that as you're helping to transport. Likewise, athletes who have helmets and shoulder pads, if you take off their helmet but they are wearing their shoulder pads, then you may hyperextend their neck. So the right thing to do, if possible, is to leave the helmet and the shoulder pads on until it can be removed in a controlled setting. If there's an airway problem, that may mean unscrewing the face mask but leaving the helmet. Of course, the airway is the priority. If the helmet has to come off, the helmet has to come off. That's A, not D. But if you can immobilize them with their helmet and their pads on, that's the safest way to do so. And this is critical because we believe that potentially up to a quarter of spinal cord injuries happen during transportation, and that should never happen. So that is Good Samaritans, first responders, not following simple protocols to protect someone's spine on transportation. How do you clear the cervical spine and determine that someone's spine is okay? In the field, I would not clear anyone's cervical spine, but what we do in the emergency room or trauma setting is to clear someone's spine, they have to be alert and able to describe whether they're having symptoms. They can't have any neck or back pain, and that means you are examining and palpating. They can't have any neurological deficit. And very importantly, they can't have any distracting injuries. So if someone has a bad femur fracture, they could have a neck injury that they're not really able to describe for you because their leg hurts so much. So anyone who has a distracting injury has a presumed cervical spine or thoracic spine injury as well and needs to be immobilized. If you cannot clear their cervical spine clinically by following through this protocol, then they need to be imaged with usually a CT scan is at this point basically the standard of care. If the CT scan is normal, then the cervical spine can be cleared at that point. In trauma, stability is determined by 3 columns in the spine. The anterior column is the anterior longitudinal ligament and the anterior vertebral body. The middle column is the posterior half of the vertebral body and the posterior longitudinal ligament. And then the posterior column is everything in the back, so the pedicles, facet, joint, spinous process, and all of the posterior ligamentous complex. And stability is determined based on how many columns are disrupted. So if just one column is disrupted, that's like a compression fracture. That is a stable injury. They probably don't even need a brace. If 2 columns are disrupted, such as a burst fracture, then that is potentially unstable. And if all 3 columns are disrupted, then that is definitely unstable. And the posterior ligamentous complex is critical. Life is kyphotic, meaning when you are upright, things tend to fall forward. So that posterior tension band, if that is disrupted, that can lead to instability. And you don't always see this on a CAT scan because you can have a serious ligamentous injury that you would see on an MRI, but the trauma CAT scan is only looking for fractures, so you have to be suspicious of that. Ankylosing spondylitis deserves a little bit of extra attention. In ankylosing spondylitis, this is an autoimmune phenomenon where the spine autofuses through the disc space. It's described as a bamboo spine. It kind of looks like bamboo. Marginal syndesmophytes, meaning these bone spurs do not bulge outward like dish, diffuse idiopathic skeletal hyperostosis. They stay contained. They can have other large joint involvement, and they typically become very kyphotic as a result of this, such as this person here. So you need to imagine someone with a spine like this. If they fall, their spine could be potentially very brittle. So if someone falls on their back, most of us who have a mobile spine, our spine can bend to absorb that trauma. But if your spine is rigid like this, it will fracture rather than bend. And when you're immobilizing that person, you need to remember that this is their natural resting posture. So if you try to correct them into more sort of normal alignment, you may actually hyperextend them and cause some harm. You never know what's going on underneath, okay? So this fractured right through the disc space, and this fractured very unstable. And these very commonly present with a neurological deficit, not only because of the displacement, but also because there's a lot of bleeding associated or hematoma, and that hematoma can put pressure on the cord. Moving away from trauma to some of the non-traumatic emergencies, this is an epidural abscess. In this MRI, you can see discitis, which is an infection of the disc space, and osteomyelitis, which is infection of the bone, and then that has resulted in an abscess in the ventral canal. Here's a very large abscess in the posterior aspect of the canal, and that creates a problem not only from structural compression to the spinal cord, but also because of vascular infarct. Risk factors, IV drug use, anything that makes someone immune compromised, such as diabetes, HIV, chemotherapy. The bacteria typically gets there either from the bloodstream or potentially from a discitis that then migrates back. It's usually staph, but it can be other things, and Pseudomonas in IV drug users is a common one. Don't be fooled if someone has normal labs. So in the setting of an epidural abscess, only half of them will have a fever and only half of them will have a leukocytosis. Usually the inflammatory markers, CRP and ESR, are elevated. Blood cultures are only positive 1/3 of the time, and surgical cultures are only positive about 2/3 of the time. It is critical when you're treating these to get a bacterial diagnosis prior to starting antibiotics, if at all possible. Bacteria-specific, culture-specific antibiotics will be much more effective than empiric broad-spectrum antibiotics. So The temptation when you see an infection for anyone besides a surgeon is to immediately give antibiotics. But if someone is not neurologically deteriorating and not septic, then it is better to hold the antibiotics until we have a culture. If you grow bacteria from their blood culture, then that is adequate to treat based on that, but quite often you will not, in which case they need a surgical culture. And then you can start the antibiotics once the cultures have been obtained. Very common to have neurological deficit, and there's a high rate of mortality. This is an epidural hematoma. Epidural hematoma means bleeding within the spinal canal, and that bleeding is venous bleeding, not arterial bleeding. There is a leash of veins that circles around the spinal cord and extends the entire length of the spinal canal. Anything that disrupts those veins can cause bleeding, so people who are anticoagulated are at risk, and these can happen spontaneously, although it's rare. Spinal injections, epidural anesthesia are also an extremely rare cause for epidural hematoma. But this is the problem that keeps me up at night, because the number one risk for an epidural hematoma is me. It can happen at 1 out of 150 surgeries, and when this happens, some of you have been involved in these cases, you have to hurry up and get that hematoma off of the nerves to protect them neurologically. Bigger surgeries are multi-level surgeries. Those are the ones that are higher risk, and they typically will happen within a couple of days of surgery. This is why we put drains in. This is why we keep ACDFs in the hospital overnight. And this is why we make people stop their blood thinners around the time of spine surgery. Even if they're on that blood thinner for a very critical reason, it's still important to stop it, because the epidural hematoma risk can result in paralysis. Some tumors will expand rapidly and cause problems. This tumor in the posterior aspect, most likely a lymphoma. And it can cause direct cord compression, and sometimes tumors can grow very rapidly. Tumor location is classified within the spinal canal as extradural, and the extradural ones are typically lymphoma or metastatic disease. Intradural but extramedullary, meaning inside the dura but not inside the spinal cord itself, and those are schwannomas, meningiomas. And then intradural, intramedullary, those are the ones that are actually in the spinal cord tissue itself. Astrocytomas and ependymomas are the common ones. The ones that we see the most commonly by far are the metastatic disease and lymphoma, extradural. In addition to causing direct cord compression, the tumors can also cause pathologic fractures and result in either instability or impending instability. The ones that are the most problematic are the lytic lesions, meaning the ones that erode bone away. Myeloma, lymphoma, and metastatic disease from lung, thyroid, or renal are the ones that are typically lytic, and they can cause a pathologic fracture and neurological demise. Stability of a spinal cord lesion. So you have someone who has known cancer, there is a lesion in their spine. How do you determine whether that lesion is likely to cause a pathologic fracture or is likely to be stable? That is based on a couple of things. First of all, location. The highest risk locations are the junctional levels, so cervicothoracic junction, thoracolumbar. That's where you go from an area of lordosis to kyphosis, and so that's a high stress region. Conversely, the immobile spine, like the sacrum, very unlikely to have a pathologic fracture. The ribs provide some protection for the thoracic spine. When there is pain, it probably means that that lesion is changing rapidly and could potentially become unstable. Lesion type, meaning lytic versus blastic. Lytic erodes bone, blastic forms bone, so the lytic lesions are more dangerous. If there has already been any spinal alignment problems, such as any shift or instability, spondylolisthesis, then that can continue to worsen. If there has already been some amount of fracture, then that can continue to worsen. And then again, the posterior ligamentous complex, if the tumor goes into the pedicles, facet joints, and so forth, then it is more likely to be unstable. Rapidly progressive cervical spondylotic myelopathy. This is the most common reason for elderly patients to have a spinal cord injury. It's not traumatic. It is from degenerative changes. And essentially, myelopathy means patients will have stenosis, spinal cord compression, and that is a degenerative condition in which the disc discs begin to bulge into the canal, and then the posterior elements, such as the ligamentum flavum, will begin to encroach, causing significant spinal cord compression. The symptoms can be subtle at first and sort of nonspecific, and certain things that we would typically attribute to old age can actually be myelopathy. So they'll get numbness, classic is burning in their hands. They get some weakness. They will find that their hands are clumsy. They have trouble turning a key. They can't do buttons. They can't do earrings. They get a wide-based gait and gait instability, and they may get urinary retention. On imaging, there's a couple of findings that we look for. So the Torg-Pavlov ratio, what that means is the diameter of the spinal canal should be exactly the same as the diameter of the vertebral body. If that's a one-to-one relationship, then that is normal, as seen down here. But when you get into narrowing of the spinal canal, then you will have 50%, the canal diameter may be 50% of the vertebral body, and that is stenosis. Anything less than 0.8 is stenosis. On MRI measurement, anything less than 10 millimeters, also absolute stenosis. Also on MRI, you're looking for cord signal changes. So if the spine is very significantly compressed, people will get what's called myelomalacia, which means that you see a white signal on the MRI, and that means that those neurons are dying. Last spine emergency for you is a massive disc herniation, and this is probably the most common thing that you will see in the office setting that causes an acute neurological change. So myelopathy, the previous slide, that is stepwise deterioration that happens relatively slowly, but a large disc herniation will happen all of a sudden and can result in significant neurological deficit. In the cervical spine, if it is central, it will contact the spinal cord, and the symptoms are myelopathy changes. If it is more lateral or peripheral, then it may miss the spinal cord but hit the exiting nerve root, and that is radiculopathy. In the lumbar spine, the vast majority are in the lower lumbar spine, L4-5 or L5-S1, and about 1% of disc herniations can cause cauda equina syndrome, which is a neurological emergency. So, for example, on this MRI, you can see this extruded disc herniation that is enormous. It's also seen on the cross-sectional view right here. These are the nerve roots crowded into the corner, and this disc is herniated and taken up about 2/3 of the diameter of the spinal canal. The vast majority of disc herniations, as most of you know, do not look like that. They're much smaller. They're just kind of like a bump here. They cause sciatica, but they don't cause a significant neurological deficit. But when the disc herniation is large enough, then it becomes an emergency. So to summarize where we've been and conclude, we talked about spinal cord injury, and that spinal cord can be injured from trauma, and it can be injured from non-traumatic things such as an abscess, hematoma, tumor, myelopathy, or massive disc herniation. What makes these scenarios challenging and stressful is these people instantly become incredibly complicated, and your decision making is very time sensitive, and you can make the wrong decision and permanently hurt someone. So what has to be going through your mind in the 30 seconds that you begin to process all of this this is the differential diagnosis of what it could be, and what do we do next. The vast majority of these need urgent surgical evaluation and decompression. Now, the severity of the spinal cord compression and the duration of the spinal cord compression also factor into this. So it is extremely common to see someone in the office who has a very slight weakness. So their ankle strength is a 4 or a 4+ in dorsiflexion. That's not necessarily an emergency. It may have been going on for months. That you'd have to be a little bit less nervous. I guess what I'm really talking about is the true 3 out of 5 or below. Those are the ones that need to be sort of rushed along. But if you ever have anything that is concerning to you, you can always text, email, or call me. If I'm not operating or sleeping, I'll get right back to you. And if you are ever, of course, nervous about something that is a true emergency, of course, they go to the emergency room and I'll meet them there. Okay. Thank you. Any questions?